Hello everybody, welcome to Cocaine, the Amphetamines, Other Psychostimulants, and Psychedelic Drugs. I'm Audrey Robinson, your guide along this journey. So when I started creating this lecture, this was the song that was going through my head, and I tried to figure out how to be able to play a little clip of it for you in this lecture, but you will just have to, Google it yourself if you haven't heard this song. It's originally by J.J. Cale, but the popular one is Eric Clapton covering it. This is what I heard in my head when I was writing this lecture. All right. So cocaine has an interesting back history. It used to be, we've all heard this, added to drinks. It was used by Freud to treat depression. And so cocaine hydrochloride can be snorted or injected. And crack is made by baking soda, water, and heat. The cocaine hydrochloride is absorbed usually in nasal membranes because it's a vasoconstrictor. It also limits its own absorption. And then 70 to 80% of it may be biotransformed by the liver. Crack is smokable. Freebase, cocaine base, which is also often called freebase, is smokable, but it's dangerous. And there's a table on Julian's page 220 with a lot of information on this. So it is rapid tolerance is built of cocaine, so needing more and more of it to reach that certain feeling, to feel a certain way about it. It penetrates the brain, it crosses the placental barrier, and it's rapidly removed from plasma, but not the brain. So it can be detected for 8 or more hours in the brain, urine up to 12, even up to 48 for the metabolite that is created when cocaine is broken down in our bodies. And it's even longer for chronic use and in different tissues. All right, so here's the mechanisms of action of cocaine. It can be a local anesthetic. It's a psychostimulant. It's a vasoconstrictor, which strongly constricts blood vessels and raises blood pressure. And beware of the use with alcohol. Cocaine plus ethanol alcohol equals that coca-ethylene, and it is more toxic than cocaine. So those, a lot of reactions happen there. Cocaine blocks all monoamine neurotransmitters, and most effects are due to the blockade of dopamine reuptake in our brains. And so that gives us that euphoric. When it blocks those dopamine reuptakes, we get that flood, that extra dopamine in the synaptic spaces, and so we get that euphoria, that euphoric feeling. And the euphoric feeling happens if 47% or more of the transporters are blocked. All right, pharmacological effects of cocaine. So there's different kinds of effects: physiological effects, psychological behavior effects, and then the after effects of cocaine. We're going to talk about all those. So physiological effects, things like increased heart rate, vasodilation, bronchodilation, blood pressure, temperature, blood glucose, blood flow to muscles, all these things are increased. Pupils dilate. There's often a freeze, kind of a numbing from the inhalation, and then a rush immediately from when it's injected. Can also have cardiac arrhythmias, convulsions, strokes, lethal cardiorespiratory arrest. It causes loss of gray matter in the neurons, especially with chronic and long-term use. The good thing to know is that with the stopping of cocaine, the gray matter can be rebuilt. So spontaneous abortion occurs in early months of pregnancy. In the pregnancy, it can also cause brain malformation, cardiovascular abnormalities, and withdrawals in 1/3 of the babies whose mothers used cocaine during pregnancy. They also saw later in life ADHD-like symptoms and a decrease in gray matter in those kids. And so one of my passions is understanding the difference between what may look like ADHD and quack like ADHD, but may not actually be ADHD, because ADHD, in my opinion, gets not necessarily overdiagnosed, but especially in the education system gets overly labeled, and that may not be necessarily by a diagnosis. It may be a teacher or a school counselor or some other administrator or educational staff saying, hey, this kid, I think he's got ADHD. We need to talk about this mom about, you know, going to the doctor, getting some kind of evaluation. But it's not always ADHD because we don't always ask all the right questions and look into the history. It's really important when working with children to check out that developmental history, which can start when working with children clients. I start with a developmental history that starts even before birth. How was your pregnancy? Was there any drug use or substance use during pregnancy? What was it like? Any trauma? All those things are clues. And so this would be a good clue if we had a kiddo who might meet criteria of ADHD, might not actually be ADHD. Trauma also looks and quacks like ADHD. All right, let's talk about after effects. So there's this letdown, and after the cocaine is leaving the system and it's being metabolized, there's this depression, dysphoria, anxiety, somnolence, and drug cravings. Stats typically 12 to 39 male, and dependent on 3 or more drugs when we look at cocaine, who is using it. There is a coexisting psychopathology in about 30% anxiety, 67% clinical depression. So that comorbidity of anxiety and clinical depression with cocaine use. The psychological and behavioral effects, we have agitation, impulsiveness, anxiety, suspiciousness, paranoia, formication, which is the sensation of bugs crawling on your skin, compulsive and repetitive patterns, and even sexual dysfunction. There's not a lot of, like cocaine, with there's effects and the attention is drawn away from sexual activity. So there's a 1 millimeter increased probability of substance use with 69 to 83%. All right, let's talk about amphetamines. So we've got dextroamphetamine and levoamphetamine. So they're the 2 isomers of amphetamines. The dextro is stronger than the levoamphetamine, which is also often just called L-amphetamine. All right, so amphetamines, longer effect than cocaine, 20 to 25% have like an early peak of the amphetamine use, and so the rest of the population has a later peak of the feelings gotten from and the effects from the amphetamines. It also modifies the action of dopamine and norepinephrine in 4 different ways in our bodies, in our brains. All right, so when we're talking about the pharmacological effects of amphetamines, we've got amphetamines, which is less strong than dextroamphetamine, which is less strong than methamphetamine. So you've got that kind of hierarchy: amphetamine, dextroamphetamine, methamphetamine. So with a low dose, you get increased blood pressure, heart rate, relax the bronchial muscles. In our central nervous system, you get potent stimulant producing alertness, euphoria, excitement, wakefulness, loss of appetite, increased mood, motor, and speech activity, and a feeling of power. With a moderate dose, you get some of the same effects as the low, more stimulation of respiration, slight tremors, restlessness, insomnia, agitation, worsening or de novo, which is new production of anxiety disorders, and neuronal dopamine system dysfunction, so problems in that dopamine system. With high doses, continual purposelessness, repetitive acts, and we kind of mentioned that a little bit in cocaine. So some of these, the way some of the side effects of this are the same in the effects of these, but it's those continual purposeless repetitive acts is more common and worse with amphetamines than it is with cocaine. Sudden outbursts of aggression or violence, paranoid delusions, severe anorexia, weight loss, skin sores, and infections. And some of those things, like the weight loss and skin sores, are caused by amphetamines, and some of it is also caused by not just the drug itself, but the way that the person lacks care, self-care for themselves, quits taking care of themselves. So it's kind of a double whammy there. So these are different effects for amphetamines, dextroamphetamines, and methamphetamines. Meth is a soul killer. It's linked to low birth weights anxiety, depression, moodiness, aggression, and ADHD-like behaviors. There we go again with what looks like ADHD and quacks like ADHD might actually be amphetamine use. All right, non-amphetamine behavioral stimulants. So when talking about these kind of classes in drugs, so we have the non-amphetamine ones. So we've got ephedrine, and that's found in nature, a Chinese herb, and it raises blood pressure, heart rate, decreases appetite. So a lot of these things were used in some prescription or even over-the-counter medications. Over-the-counter things don't actually get called medications. They often get called supplements, and that means that they don't have to go under FDA approval, which is scary in my opinion. So you may have heard of like ephedra, and depending on how old you are, you may have remembered having like those commercials that are class action lawsuits for some of those different things because of the major heart side effects. Then you've got pseudoephedrine, and you may remember that from cough and cold. It used to be sold over the counter back in the day. When I worked in pharmacy, I remember it was sold over the counter, and then it went behind the counter in pharmacy, and you had to show your driver's license, and we logged it into a system. We had to run your driver's license, and we would see there's a huge database, and you could see how many you bought, and we could only sell a certain number. Early on, there were ways around that system, but then the system grew to be bigger and bigger. So that stuff's all behind the counter now in the pharmacy. Something called CAT, which is cathinone, herbal substance from the Catha edulis shrub in East Africa. Then you have synthetic cathinones. Those would be the things that we might have heard of called bath salts, mephedrone, methylone, and MDPV, which is a really long pharmaceutical name that I'm not even going to attempt to pronounce. So you have flaca, which is that A-PVP, alpha PVP. It's a second generation bath salt. They're colorful crystals that dissolve orally. And then DMAA, which is supposedly a natural substance, which isn't actually a natural substance. This is another one of those occurrences where somebody said, oh, we think it maybe comes from the geranium plant. But then when scientists actually have done studies, they said, no, it doesn't come from the geranium plant. That's just some way these people used to cover up and get something that's a possible dangerous substance into a quote-unquote health supplement. Non-amphetamine behavioral stimulants, again, we've got methylphenidate, phenyline, and modafinil or armodafinil. So methylphenidate, you guys have heard of this. This is Ritalin. It's one of the most researched drugs out there because of the extensive amount of research that's gone into it. It's been on the market a long time. So the regular release Ritalin works for 2 to 4 hours for ADHD, and that 2 to 4 hours depends on differences in the individual person. It works by increasing the synaptic concentration of dopamine by blocking the presynaptic dopamine transporter. Very similar to cocaine. It is not cocaine. And it blocks 50% of the receptors 60 minutes after an oral dose. Then you've got phenyline, which its drug name is Cylert. It works on the central nervous system. Stimulant. It's no longer on the market for ADHD due to hepatitis. It would cause problems in the liver. Then you've got that modafinil, armodafinil. So this is Provigil or Nuvigil is the brand name of these drugs. We often are saying the generic name, which every drug has a generic name, whether there's actually a generic of it, and then the brand name. And so the generics are able to be made after their patents expire, kind of a little bit into that. So it's a psychostimulant for wakefulness, wakefulness promotion, and it's used for narcolepsy, shift work sleep disorder, and obstructive sleep apnea. And that it's used for the obstructive sleep apnea when the traditional methods like the masks and those things that are normally worn with sleep apnea don't work. It's not a first line for sleep apnea. All right, now let's talk about the treatment of stimulant dependency. And the book talks about a ton of methods that don't necessarily work. Talking about dopaminergic, adrenergic treatment, GABAergic, glutaminergic treatment approaches, drugs, pharmacokinetic approaches, and vaccines. And it talks about a bunch of different things that have been tried and that might work in theory, but that don't actually work. And some of that is due to the individual differences in that when you're treating one receptor or one area, it's hard to treat that specifically and not all the areas. So a lot of the side effects were untenable for many of these methods. All right, so we've got different classifications of psychedelic drugs. Anti-Cholinergic, which you often hear this word in reference to like sinus medication. A lot of those different medications are used for their drying effect because they're found to have worked on the nasal passages and those things. But it's also a competitive agonist of the muscarinic type of ACH, that's the acetylcholine receptor. An example of that is scopolamine, which is often used for like anti-nausea for like going on a cruise or something like that, as a patch behind the ear. So a lot of these that have psychedelic properties also have many other uses that we've found. Then there's your monoaminergic, which is like your MAOIs, and we're going to talk about those when we get on to antidepressants as well. So they are there are different types of this: serotonergic, which would be LSD, psilocybin, DMT, catecholamine, mescaline, MDMA, and MDMA derivatives. And there I list some of the MDMA derivatives there. And then we have, breaking those down, the serotonergic, which is LSD. It's absorbed orally. There's different phases it goes through: the somatic phase, which would be like you're in your body, sensory phase, the psychic phase, and then there's some other kinds: DMT, bufotenine, psilocybin. I'm not gonna try to pronounce that one. And then harmine. Then you have synthetic amphetamine derivatives, and that's MDMA and then all of its derivatives. You have glutaminergic NMDA receptor antagonists, and that would be phencyclidine, ketamine. You guys have heard that, vitamin K. I'm sure some of these things are ones we've heard of. Methoxetamine, dextromethorphan, and that one you'll recognize as being in cough medications. Opioid kappa receptor agonists, and the one that your book talks about is salvinorin A. All right, so as always, why are we talking about illicit drugs? We know there's a whole class about drug abuse and alcohol abuse, and about several classes that you may take, and several books that focus more on this. This is all about discernment of presenting symptoms with our clients, knowing the difference between an LSD trip and a schizophrenia paranoia is important. So LSD often causes symptoms that are linked to the environment. So those delusions are linked to things that are actually really physically there in the environment. Whereas with schizophrenia, most of the time the hallucinations are auditory, not visual, and definitely not physical touch. Those kinds are much less common and usually associated with more severe forms of schizophrenia. So it's important to know these things, because you have someone who comes in and they start talking about hallucinations. You know to yourself, well, where were you when this was happening? Oh, I was in my room and suddenly the couch started talking to me. That sounds more like a drug trip than it does like a schizophrenic hallucination. Or the couch started changing colors. That's linked to the environment. It's more visual than it is auditory. And so by knowing some of these things and talking with your clients, you can help discern and help know how to approach these things. This is the best way to help our clients. We never want to recommend things without going fully into the background history, knowing what's going on. And so we don't want to also jump to conclusions without really getting some more information and really supporting our clients through what they go through. And like I said, a big passion for me is knowing that things might look like ADHD and quack like ADHD, but not actually ADHD. And I say that because the saying, it looks like a duck, it quacks like a duck, then it probably is a duck. Well, in the case of ADHD, it might not be. All right, so as always, here is where this information comes from, your book, and I look forward to seeing you next time.